I'd like to welcome you all today to our webinar series. A few things to note. Participants will be muted upon entry and videos turned off. For technical assistance, we ask that you please use the chat box located at the bottom of your screens. You will also receive an email in approximately 3 months requesting feedback and impact on today's presentation. Immediately following this webinar, you will also receive a handout containing the slides and any references provided by today's presenter. We also ask that you complete the evaluation form that's accompanied with that information in the email presented. And lastly, for other educational opportunities, we ask that you visit www.ncedas.org/training to view any other training opportunities. I'll now go ahead and introduce today's presenter. Our presenter today is Dr. Christine Peet, the Director of the National Center of Excellence for Eating Disorders, also known as NCEED, and an Associate Professor of Psychiatry at the University of North Carolina at Chapel Hill. She completed her undergraduate training in psychology at the University of Arizona and earned her master's degree and doctorate in clinical psychology at the University of North Dakota. Her internship was in behavioral medicine at West Virginia University, after which she went on to complete her postdoctoral fellowship in eating disorders research at the University of North Carolina under directorship of Dr. Cynthia Bulick. As the director of NCEED, Dr. Peet is focused on broadly disseminating education and training on eating disorders to healthcare providers across a variety of disciplines. Her research centers on eating pathology across the spectrum, but with a distinct focus on binge eating disorder. She's particularly interested in the intersection between obesity, bariatric surgery, and eating pathology, and investigating physiological comorbidities associated with eating disorders. Dr. Peet is also a licensed psychologist in North Carolina, and as such, treats eating disorders across the spectrum with a primary focus on binge eating. Given her background in behavioral medicine, she has also established clinical services in GI surgery, where she provides both psychotherapy and behavioral medicine interventions to this patient population. In addition to her clinical and research responsibilities, Dr. Peet is also a clinical supervisor for predoctoral psychology interns, psychiatry residents, and mentors undergraduate research students. I'll now turn things over to Dr. Christine Peet.
Wonderful. Thank you so much, Lachelle. Thanks everybody for being here this afternoon or this morning or this evening, depending on where you are in the world. As Lachelle indicated, I am Christine Peet. I'm the director of NCEED, and I'm really thrilled to have you here with us today. We're going to talk a little bit about some of the work that we have been doing in terms of developing a novel screening tool for use in primary care. We'll talk a little bit about the protocol itself and then where we're headed down the road. And I'd love to hear any thoughts or comments or suggestions that you all have as you learn more about this tool, given that we really want it to be something that's useful for the field and something that, the more feedback that we have, the better we believe that it will perform. So feel free to be using the chat box along the way to send questions over. And I know that there'll be time at the end, and Lachelle will be helping to facilitate some of that question and answer session. All right. So before we kind of dive into the main part of today's content, I just wanted to draw your attention to our website. For those of you that may not have attended any of our webinars or who may be new to NCEED, our website is down here at the bottom right of your screen, and there's just a quick snapshot there of our homepage, really just kind of giving you an overview of what we provide in terms of the library of resources, the training page. We have different stakeholder groups that we know will be using our website. So there's information for healthcare providers, which of course would include mental health care providers like psychologists, counselors, in addition to our medical providers, our physicians or nurses. And then we also have curated information for individuals with lived experience, in addition to family members and friends. So please feel free to make use of the website and all the resources that are there. Everything is available free of charge. In terms of what we're going to talk about today, there's just a brief roadmap. I'd like to kind of set the stage and describe eating disorder diagnoses and the overall burden. I know that many of you in here are familiar with eating disorders. This is your life's work, but I just want to make sure that for everyone who's in attendance, we have a shared understanding of what we're talking about when we refer to eating pathology. We'll also talk a little bit about identifying patients who might be at risk for underdetection of eating disorders. And then finally, I'll be able to share with you a little bit about our protocol that we've developed for screening, brief intervention, and referral to treatment of eating disorders. Many of you are probably familiar with some of the information on the next couple of screens, but for those of you who are not, there was a report that was done in, I believe it was July of 2020, in collaboration with Deloitte Economics, Striped, which is a public health group out of Harvard, and also the Academy for Eating Disorders, to really look at the social and economic burden of eating disorders in the US. And so what I'd like to draw your attention to here are some general statistics that I think will be important as we're thinking about setting the stage for today's talk. So what this report found was that roughly 28 million Americans will struggle with an eating disorder at some point in their lifetime. So we're talking about roughly 9% of the US population. And I think that this is a statistic that even though many of us might work in eating disorders are still kind of surprised by, given that oftentimes there's this narrative out there that eating disorders are rare kind of niche conditions that most people will grow out of if it's a phase, those sorts of things. But really, we're talking about a fairly significant population of the US, and that these are particularly serious illnesses. In fact, it was estimated that there would be over 10,000 deaths per year as a direct result of an eating disorder, such that one person will die every 52 minutes as a result of their condition. One of the important points that we'll spend some time talking about today too is that eating disorders do affect everyone. We know that there are rampant stereotypes about eating disorders, but we know that at this point, based on the research that's been done, that eating disorders don't discriminate based on your age, your race, your gender or sexual orientation. And so it's really important for us to be thinking about all the people who might fall outside of that traditional stereotype of an eating disorder. In terms of the overall cost to society, we know that eating disorders cost somewhere around $64 billion per year in terms of things like direct patient care, loss to economic productivity, all kinds of different costs that you can see broken down here. For those of you that are interested, there's also state-by-state information from the Deloitte report. So if you're wondering about what kinds of prevalence estimates or what kinds of costs might be going on in your particular state, you can find that information online. I'll make sure that that gets sent around as well, in addition to today's slides. So again, this is just kind of setting the stage for what we're talking about when we refer to eating disorders, how pervasive they might be, and how much of a problem that they are, both in terms of the human cost, but also the economic cost. When we're talking about eating disorder diagnoses, there are a number of different things that I'm sure you all are familiar with, but I wanted to talk a little bit about some specifics so that we can kind of be thinking about these diagnoses as we move through the talk. So the first diagnosis I'm going to start with, so somewhat atypically, is other specified feeding and eating disorder. And I'm starting with this diagnosis intentionally. So for those of you that are routinely work with eating disorders, it will come as no surprise that this is actually the most common eating disorder diagnosis. For those of you who may be less familiar, when we're talking about this OSFED condition, we're really talking about eating disorder symptoms, eating disorder behaviors, thoughts that don't necessarily meet every single diagnostic criterion for, let's say, anorexia nervosa or bulimia nervosa. We can kind of largely conceptualize this as kind of that spectrum of eating pathology where someone may not meet every single frequency criterion or meet every single diagnostic criterion, but they still are struggling in some way with their relationship with food, their relationship with their body. Part of the reason that I'm highlighting this here is that given that we're going to be talking about a primary care screening tool, I think it's important that that's kind of the mindset that we have when we're thinking about screening for eating disorders. We're not necessarily screening for individuals who have very obvious signs or symptoms of an eating disorder, or who may come to us explicitly knowing that they've been diagnosed with an eating disorder. Many people that we're really trying to screen in primary care may lack some of these obvious signs and may end up falling into this kind of OSFED category. The other diagnoses are ones that many of you are probably familiar with, things like anorexia nervosa, where the defining feature is this intense fear of gaining weight, such that the individual is restricting their energy intake to the point where they're losing a significant amount of weight, or they're engaging in behaviors that interfere with weight gain. I think this is a very common diagnosis that many of you are familiar with in pop in larger cultural circles, just things to be aware of in terms of, low body weight, preoccupation with food, eating, and calories. We can talk more about the nuances of these diagnoses in the question and answer session. I'm happy to do that, but for the purposes of today's talk, I'll just keep moving through. Bulimia nervosa is another eating disorder diagnosis. It's characterized by binge eating episodes and then paired with what we would call these inappropriate compensatory behaviors. So these are going to be things like self-induced vomiting, compulsive or driven exercise, laxative abuse, diuretic abuse, and usually they're temporally paired such that someone's having a binge eating episode very closely followed by one of these kinds of compensatory behaviors. Binge eating disorder is very similar to bulimia nervosa in that both are characterized by binge eating episodes, but for this particular diagnosis, individuals are not engaging in those compensatory behaviors on a regular basis. So these are folks that are having recurrent binge eating episodes where they feel out of control. They might be eating large volumes of food, feeling guilty, ashamed, or disgusted with themselves afterwards. And then avoidant restrictive food intake disorder is an eating disorder diagnosis that's characterized by a persistent failure to meet nutritional or energy needs based on your age, developmental stage. And you might be thinking that this sounds very similar to anorexia nervosa, but this is actually a condition in which someone does not have that same sort of drive for thinness or a drive for weight loss or a fear of weight gain. These are individuals that might not be meeting their nutritional goals because of sensory characteristics with food or aversive experiences with food that have led to some degree of anxiety around eating. So there are, again, some diagnostic nuances here that we can discuss, but that's largely what we're talking about for today's purposes when we refer to eating disorder diagnoses. One of the things that I also do want to spend some time talking about is this misperception that there is a look for individuals that have an eating disorder. And I think it's particularly important to be talking about that when we're thinking about a primary care audience. So I think oftentimes we might be expecting that if someone has come in losing a certain amount of weight or someone who might fit a certain stereotype of eating disorders, whether that's young, white, cisgendered female, then we might think of screening those individuals for an eating disorder. But we know that those are the stereotypes that are actually the most misleading because eating pathology really is a spectrum and there isn't any particular look for someone with an eating disorder. In fact, we know that many individuals who are a part of a marginalized community may actually be at particular risk for an eating disorder. So individuals living in higher weight bodies or larger bodies may not necessarily be screened for an eating disorder or even have that be a part of their differential diagnosis because they don't fit that stereotype. But any individual can struggle with an eating disorder irrespective of their body weight or shape or size. Individuals who come from racial or ethnic minorities may also not be routinely screened for eating disorders, but they certainly struggle with the full spectrum of eating pathology. And then individuals with food insecurity may also be struggling with all forms of eating pathology. And this is something we've seen clinically here at UNC, and there's a good amount of research now being looked at food insecurity as a risk factor for eating disorders. I highlight some of these here to really get you to start thinking outside the box of what you might typically consider when you're thinking about an eating disorder diagnosis. So instead of having one particular stereotype in mind, we're really thinking about the reality of eating disorder diagnoses. These are going to be individuals who look like your family members, your friends, your neighbors, your colleagues. So keeping that in mind as you're in your routine clinical practice can really help expand the number of individuals that we detect with eating disorders. In terms of the overall burden, I'll spend just a little time talking about the medical complications as well as the psychiatric and social complications. We know that depending on the diagnosis, eating disorders really can affect all organs and systems. Malnutrition in particular has deleterious effects on all body systems. We also see a lot of folks coming in with GI complaints, whether that's some form of indigestion, constipation, maybe bloating, just some kind of stomach irritability is very common with eating disorder diagnoses. There can be some very dangerous effects on your cardiovascular system associated with dietary restriction, overexercise, laxative abuse, self-induced vomiting, the list goes on. And then, of course, there are some very real psychological and social complications with respect to eating disorders. So we know that folks that struggle with these conditions often have just this running tape player of information and negative eating disorder thoughts running through their minds. And this can lead to some real difficulties when it comes to attention, being present in your workplace or at school. And this can also lead to things like impaired social functioning, where folks with these conditions become so wrapped up in their eating disorder, they become isolated from their family and friends. The eating disorder becomes so important that it pushes out all of the other parts of your life. So when we're thinking about that overall picture of eating disorder burden, we're really not just talking about the relationship with food, relationship with body, or your weight. We're kind of talking about your overall quality of life. We talked a little bit already about some of the medical complications, so I'll skip over that for these purposes. But in terms of some of the psychiatric diagnoses, I think it's important, especially for those of you who might be generalists, to be aware that eating disorders are commonly comorbid with other kinds of diagnoses that you might more routinely see in your practice. So substance use disorders, somewhere between 27 and 36%. Mood disorders and anxiety disorders are pretty ubiquitous when it comes to eating disorder comorbidity. There are very few patients I can think of that I've ever treated that didn't have a comorbid mood or anxiety disorder. So it doesn't hurt to kind of be thinking about an eating disorder as a possible comorbid condition if you have patients in your practice who also have things like substance use disorders, mood disorders, or anxiety disorders. Despite the fact that we know that there is significant morbidity and mortality associated with eating disorders, there's some really difficult clinical realities. So we know that eating disorders actually have the second highest mortality rate of any psychiatric illness. And really this is largely secondary to substance use disorders, in particular opioid use disorder. So many people are surprised to learn that, but eating disorders are very deadly conditions. And many individuals with eating disorders will die as a result of suicide. And even more frustrating is that even though these conditions are really serious, life-threatening, maybe at best, half of individuals with these conditions will receive treatment that they need in order to get to recovery. And even if they can find treatment, even if they are detected with an eating disorder, finding that treatment can be really challenging. So any of you here that work in mental health, and even those of you that don't, are aware of how challenging it can be to find treatment in your area with your insurance company. And doing that with a specialty kind of treatment like eating disorders gets even more complicated. There are a number of different barriers to detection, reasons why this isn't happening. Some of this we've already talked about with respect to stereotypes around age, gender, weight, race, or ethnicity. But there's also an under-recognition of diagnoses that aren't anorexia nervosa, which is part of why I started with OSFED when we were talking about diagnoses. I really want you thinking about what you're more likely to see in practice versus what you're less likely to see in practice. And so because of that, I think it's important that we're thinking about that full spectrum of eating pathology, not just one particular diagnosis. We also know that very similar to things like substance use disorders, those with eating disorders are actually more reluctant to disclose their symptoms. It's not usually the case that folks wake up and think, I have an eating disorder, I need specialty treatment, I will go to UNC and get care. Usually these are conditions that really thrive in that isolation. And so folks are doing everything that they can to conceal their eating disorder, not talk about it, not acknowledge it. And so in that way, it can be really hard to detect these folks, again, much like those with substance use disorders. The good news, however, is that early detection can play a crucial role in detecting folks with eating disorders, getting them to the care that they need, and helping them have a better overall prognosis. So as I mentioned, it's rare that patients present directly for specialty care. However, there are many instances in which these individuals might be better detected in a primary care setting or even in a generalist mental health clinic. So in these situations, these patients often have ongoing relationships with their PCPs. I can't tell you how many times I've worked with patients who have said, I've been working with my primary care doc for 5, 10, even 15 years. And that kind of relationship is so meaningful and so longstanding that it's kind of the perfect opportunity to introduce these kinds of screening measures. Those that are in a primary care role or in a more generalist role are also in a really great position to help facilitate referrals to more specialty type clinics. So there are lots of reasons that the primary care or the generalist setting might be the perfect role to be doing this kind of screening. And again, as with almost every mental health condition, every physical health condition, the earlier we can capture these things, usually the better the prognosis. Certainly that's not the case widespread, but overall, usually it means better things in terms of outcomes. So if you're asking me or anybody else in the eating disorders field who should get screened for an eating disorder, we're pretty biased and we're going to say everyone should be screened. We know that given the research that's out there and the statistics that have been compiled, that anyone can struggle with an eating disorder. But knowing, of course, that we live in the real world where there are practicalities in terms of bandwidth for screening, time for screening, I thought I'd highlight a few areas where there is some higher risk for the onset of eating disorders. So one group I'm sure won't surprise you, adolescents, those that are kind of in those formative years, right around puberty, and then thinking about that high school to college transition. These are folks that you have a demonstrated risk of eating disorder onset. Also in that same vein, patients in any kind of key transition periods. So you think about, transition from college into your first job, you think about weddings, you think about the first child you might be having, all of those kinds of major transition points are important to keep in mind as high stress times that might trigger an eating disorder in folks who are biologically vulnerable to developing them. Folks with certain medical conditions are also at higher risk for eating disorders. So those with diabetes, PCOS, any kinds of GI complaints, these are folks that it's super helpful to be thinking routinely about whether or not an eating disorder might be comorbid with what's presenting in the clinic visit. Also athletes, for probably fairly obvious reasons, are at high risk. Anyone with a family history of eating disorders, given that we know the genetic loading or the biological predisposition to developing an eating disorder. Anyone seeking help for weight loss is an important group for us to be screening for eating pathology, given that we know that major risk factors for eating disorder onset are things like history of dieting, a history of living at a higher body weight or in a larger body. And then veterans are also a group that have shown some increased risk for the development of eating disorders. There are lots of reasons that we could go into there, but suffice it to say that there are lots of things that might set you up for an eating disorder when you make that transition from being in active duty into the veteran status and going back to civilian life. Let's see here. I apologize. Let me go back one screen. Okay, sorry about that. There was a little bit of funniness on my screen. So as we've talked a little bit about setting the stage for eating disorder screening, the importance of doing this screening, sort of the severity of eating disorders, one of the things that we as an organization really found was that even though providers really wanted to screen for eating disorders, primary care docs were telling us, sure, I'm happy to do this. I'm happy to help play that role in terms of mental health screening, which they're of course being increasingly tasked with. But I need something that's pretty specific to my practice. I need something that's going to work in a primary care setting where we might have 15 minutes with a patient. And during those 15 minutes, we have to take care of a list of all of their other diagnoses. And now we're going to introduce something else, right? So they needed something that was pretty specific for their practice. So what we thought about doing was really leveraging an existing framework that many of you may be familiar with and making the content relevant for eating disorders. So for those of you that are in a generalist setting or a primary care setting, or anyone who does substance use disorder work, you're probably familiar with the screening, brief intervention, and referral to treatment model, where this is sort of a public health model that's based on harm reduction. The idea that if we can get PCPs and other generalists engaged in this kind of early detection piece, then it will set folks up for better outcomes when it comes to their substance use disorder treatment. So what we did is we took that existing framework that has been developed in coordination with primary care docs and has been widespread throughout primary care practice, also in medical education, and we've swapped the content out to be relevant for eating disorders. I'll talk a little bit about what that means and what that looks like, but essentially we did this through really in-depth input from primary care providers. As a clinical psychologist myself, I am not a PCP, so I will not pretend to understand what it's like to see that many patients in a day, to have such short visits. And so we really wanted to make sure that what we were developing was going to be relevant for them in their practice. So we did a series of qualitative interviews that we'll talk a little bit about. But this whole protocol is really designed to give providers an evidence-based screener, ways and words that work with their patients who are in front of them struggling with an eating disorder, and then getting them to that specialty care for people like me who treat eating disorders specifically. We did this in a way that gives PCPs really concise information. It's easy to access and it's plug and play, because we heard from them over and over and over again, it needs to be quick, it needs to be easy to use, and it has to be kind of this just-in-time type information. All right, so to undertake some of this work, we worked with a group that's here at UNC called CHI-CORE, and they're really well connected here at the university, and their whole ball of wax is really developing these kinds of digital interventions and making sure that they are relevant to the stakeholders who are using them. So we worked with them to do some of this initial development work, where we did a series of qualitative interviews. We recruited primary care providers, those who had familiarity with eating disorders, those who didn't have any familiarity with eating disorders, some that were working in purely primary care offices, some that might be working in college settings. We tried to get as wide a range of these types of stakeholders to really get a full breadth of understanding in terms of the needs for some of these folks when it comes to managing eating disorders in their practice. What you're seeing here, I know, is small print, so forgive me, but what you're seeing here are some screenshots of some of the interview guides that were used when working with the PCPs for these qualitative interviews. So they were asked a little bit about their experience with eating disorders, what do they know about these conditions, how many patients have they treated with eating disorders, or how many do they suspect that they've treated with eating disorders. We gave them some general information about the SBIRT framework, and then we asked for some explicit feedback from them about the pros, cons of this kind of approach. Is this something that would be useful for them in their practice? Is it not? What are the features that would work well? What are the features that wouldn't? Audio recorded all of these interviews and then pulled out all of the information as we were moving through. And I'll talk a little bit about these next steps. And for those of you that are in the digital health space, you're probably very familiar with this work, but we did a series of iterative user experience sessions where we sat down as a group here, our NCEED group, in addition to the CHI-CORE group, and really thought about, okay, based on what we've learned from these qualitative interviews from the primary care docs, let's develop some of these different personas. What types of PCPs do we think at some point might be using this tool? What kind of practice do they work in? Are they in a rural setting? Are they in a more metro setting? Do they see mostly adults, or do they see more children? Are these folks that are new to practice? Or they've been practicing for 30, 40 years? Again, when we're thinking about doing this launch, we're really thinking about doing this on a national scale. So it was important for us to be thinking about the full range of stakeholders who might be using this tool at some point. And so we came up with a number of these different personas. We paired them up with different types of patients that they might be seeing. Everywhere from a patient who says, I know I've had an eating disorder, I've been diagnosed, but I really don't necessarily want to address it, all the way through folks who would have never conceived that they were actually struggling with an eating disorder. They thought it was just them. It was just a condition that they had struggled with their whole life, but just sort of figured it was idiosyncratic to their experience. And so in this process, it really got us thinking about, okay, given the complexities of the different types of PCPs that are out there, given the complexities of the different types of patients and the different diagnoses that might be coming up, and then you think about the matrix where all of those things kind of intersect, we really started to think about how this tool might need to function to meet the needs of all of those different kinds of stakeholders. And I hope what you're really getting a good sense of here is just the complexity when it comes to developing a tool that's going to address the needs of all these different kinds of stakeholder groups. And so with that in mind, let's see if I can get this to work. We developed some wireframes where we started thinking about, okay, if we take this down to brass tacks, what are the features that are going to be most important? We know that there needs to be a screener. We know that we need to give providers some specific words to use in working with their patients. We know that we're going to need to give them some sort of outcome, that they're going to be able to learn something from the results of this screener and then be able to do something about it. Because that's what we heard over and over again from the primary care docs, was that I'm happy to help, I'm happy to screen, but if I'm going to screen for something, I need to know what to do about it if somebody screens positive. I can't just be left holding the bag knowing that someone has an eating disorder and not then being able to document that I've done something about it. So we started to come up with some of these initial wireframes, thinking about, everything down to what kinds of, what way would we want these buttons to look, right? Would we want these to be radio buttons? Would we want these to be text boxes? All these different things that I think when you look at something on your phone, you're already just kind of used to looking at it. You're used to seeing things presented in a certain way. But when you're building it from scratch, there's a lot of these decision points to make. And so what I'm going to show now is just a series of screenshots for the tool that we have done a mock-up for. This is not our final offering. This is just the mock-up that we've developed with CHICOR, and I'll talk a little bit about where we are in terms of development after we've had a chance to walk through this. But this overall is the mock-up for the website that we have now developed in collaboration with CHICOR, or that we have mocked up with CHICOR, I'm sorry. And you might be wondering at first, did she just say website? So this is going to be a website, not an app. And the answer to that question is yes. We heard overwhelmingly from our primary care docs that there is no way that they were going to download a native app onto their phone, pull out their phone during a clinic visit, pull up that app, enter the information, and then somehow have to email that to themselves to put it into the EMR. There were just too many points of friction, too many points in which they might stop and not actually use this tool. But when asked if they would use a freely and publicly available website, is that something that they would have an appetite for? The answer was yes, that if this was available to them, easy to use, they could download a shortcut on their laptop or on their tablet, that's something that would be more amenable to their practice. So we've built this as a website. This would be the homepage that you would see when coming to the website. This gives you some brief information about SBIRT and what it's for. You would then click the Get Started button, and you're presented with the first two screening questions. Those of you that are familiar with eating disorder screening, you're probably familiar with the SCOF, and the SCOF is what we have used for the purposes of this particular SBIRT for eating disorders protocol. What you're seeing here are the first two questions, not necessarily in terms of order, but there were a couple of research studies done looking at which of the items from the SCOF were the most sensitive, which were the ones that were really going to be the best at overall detecting eating disorders. And you might be wondering why we're doing this, especially for those of you that are eating disorder clinicians, eating disorder researchers, thinking, oh my gosh, we're losing a ton of nuance here. And you're not wrong. But the reality is in primary care, you have maybe 15 minutes. And in those 15 minutes, you have a ton to accomplish. So we don't have the luxury of time of administering even a 28-item measure like the Eating Disorders Examination Questionnaire, for example. And in fact, when you look at other screenings that are done in primary care, things like anxiety and depression, they have whittled down those screeners to just a couple of questions. So many of you are probably familiar with the PHQ, the PHQ-9, the PHQ-7, the PHQ-2. And the PHQ-2 is what is routinely used to detect depression in a primary care setting. So when we thought about, again, how can we get as many PCPs to use this as possible, we thought about making the parallel to other things that they're already screening. So we picked the two items that were found to be the most sensitive. If a patient were to answer no to both of these questions, they would be considered a screen negative. If, however, a patient says yes to either of these questions, then they're administered the final three questions from the SCOF. And these radio buttons are just filled in to give you a sense of what that would look like when they're completed. So once all 5 questions have been administered, for those who said yes to either of the first two, the provider is then given a results page. So in a matter of 2 clicks, we've gotten to a place where the PCP is given the results of the screener, what they're going to do next, and then the patient-facing information as well. And I'm going to walk you through each of these in turn because I know it's a lot to look at. But if you look at the top of the screen there, where the yellow box is, where it says medium risk, or risk level medium. This is just a mock-up of a patient who might be determined to have a medium risk for an eating disorder. I know it's somewhat arbitrary, but again, we were thinking about all the parallels that exist when it comes to other screening conditions that PCPs are engaged in. So if you think a little bit about alcohol use disorder, for example, that's actually what SBIRT was originally designed for, was for the management of alcohol use disorder in primary care. And when you do an alcohol screening, a PCP is told your patient is at medium risk for an alcohol use disorder because he or she is drinking X number of drinks per week, or they're high risk for an alcohol use disorder because they're drinking even more drinks than that per week, for example. And so we wanted to have a parallel when it came to eating disorders. So what we've given here is, just for an example, a medium risk level for an eating disorder. And then that whole box is something that they can click and then immediately put into the EHR. And what's here is very parsed down, it is very brief, but it's what our PCPs told us in terms of how they document each of the problem areas. So they need to know what the results of the screener were. They need to be able to document what it is that they did as a result of those screening results, and then what they're going to do next at the next visit to make sure that this is a continuing plan of care. So we've mocked up this kind of language. And again, we are open to iterations. We're open to refinement, especially based on feedback when folks start to use this. But this is kind of what we've initially envisioned for this section for primary care providers to put into the EHR. So that's kind of that first page in terms of the results. At the bottom of the screen, what you're going to see is kind of that brief intervention component of the SBIRT protocol, where we've given providers ways and words that work. What are some of the things that you want to say to a patient if you know that they've screened positive for an eating disorder? And again, this goes all the way back to our initial qualitative interviews that we did. Our PCPs told us, listen, I am fine with doing the screening, knowing that there's an evidence-based measure out there, that's great, but what do I say to this patient so that I don't make their eating disorder worse? What kinds of words do I want to use? How do I talk about food and weight in a way that's compassionate and informed, and is in a way that isn't going to necessarily make them feel even worse about the fact that they've screened positive, or worse in terms of their eating disorder? So we've come up with a series of different scripted prompts in some of these different areas. The expectation is not that the PCP will cover every single one of these areas in the course of the visit, but they might pick the areas that are most salient to them. So maybe they want to have a conversation about the specific responses from the screener. Maybe they want to talk a little bit about the risks of some of engaging in some of these eating disorder behaviors. Or maybe they just want to talk a little bit about reducing overall stigma to help increase motivation to seek specialty care. So on the next screen, you'll see sort of the expansion of one of those accordions, where you can see the content of some of those scripted prompts for the primary care providers. Again, these are just examples of text. These are not best and final. This is what we have in here for now, just helping folks think about, how would I approach someone who I'm concerned about an eating disorder? And so we've given them just some general starters for those topics of conversation. And I'm just going to check my slides real quick. Yes, I want to go back to one. So then what I don't have are the available text for each of the other accordion areas, but it's a very similar kind of process where the PCP can choose any of these different areas and then engage in conversation with their patient based on the areas that might make the most sense in that visit. And then in terms of next steps, in terms of that referral to treatment component, it's the step-by-step referral guide that we have developed. It is designed to be patient-facing, but it has a lot of utility for providers as well. So what we're thinking about in terms of this step-by-step referral guide is this is something that can be given to the patient in a number of different ways, and really walks the patient through how to find care in their area based on their zip code or their city and location, based on their insurance status, all of those sorts of things. And then it actually gives the patient a script of what to say when you're calling those places, or an email template if you're emailing them, just to try and take a lot of the guesswork out of it. If any of you have ever been in a position where you are referring people for specialty care, it's one of those things that I think you recognize there's a lot of onus on the patient to do the setup of these appointments or to call these places. And it can be intimidating to do that if you don't know what to say. So we've tried to take a lot of that guesswork out of there and put all of this in a comprehensive step-by-step referral guide that patients can have access to. And we'll talk a little bit about that here in a moment. In addition to all of that, we also have some static resources that are available in terms of self-help, right? So we've given patients access to widely available self-help resources. Again, these are just quick examples. This is not an exhaustive list, but just information for folks to be aware of so that they know that there are some things that they can be working on while they're waiting for a callback or while they're waiting for their first appointment, those sorts of things. So when you think a little bit about the overall workflow, what you can see is that we have developed these different components to fit into the screening, brief intervention, and referral to treatment model. So the screening, of course, is the SCOF, and that's where somebody can either be a screen positive or a screen negative. If they're a screen negative, then there aren't any further steps. If they're a screen positive, then you move on to that brief intervention component. And that brief intervention component mostly consists of those scripted prompts, the patient-facing referral guide, and then the scripted prompts and the patient resources. And then the referral to treatment component is that referral guide. It's the information that we have in terms of giving that directly to the patient, but then also making sure you follow up on that referral process at the next visit. Because again, sometimes people's motivation can lag, sometimes it gets lost in the shuffle, or folks aren't quite motivated to make any changes at that point. And that again is where that PCP role can be so crucial, because if you're having regular follow-up visits with these folks, whether it's once every 3, 6, 12 months, it gives you the opportunity to raise the conversation again in a way that leverages your existing relationship. In terms of the overall flexibility, as I mentioned before, not only were we thinking about the different kinds of providers that might be out there, the different kinds of patients that might be out there, we also recognize that the overall settings are really going to vary depending on how well resourced you might be. So, for example, when we're thinking about giving a patient that step-by-step referral guide, there are some clinics out there that are super well resourced and are going to be able to give patients fancy tablets in the waiting room to fill some of these measures out. Maybe they have a digital EHR that can send them these different things, but there are also going to be places that are still relying on paper and pencil measures. And so when we're thinking about a nationwide launch, we wanted to make sure that we were really adequately capturing the full range of different types of clinic settings that are out there. So really this whole framework was designed to be as adaptable as possible, making sure that anybody who wants to use it can use it in a way that makes sense in their practice. Are there tweaks still to be made? Sure. But this is, I think, sort of the best offering that we have at this time to make sure that folks can use this in a way that's relevant for their practice and their population that they're seeing. In terms of overall next steps, we posted the request for proposals to work with a digital health company to actually go ahead and do the build of this SBIRT website in November. And you can see some of the next steps here. Oops, excuse me, my screen is not working. So we did that in November. We selected a vendor. This was probably a week ago or less than a week ago. And we anticipate doing a launch doing the development in late 2021 with a launch anticipated in early 2022. So what you're seeing here today is really a sneak peek of what's to come. We are very excited about the vendor that we'll be working with. We think there's going to be some great opportunities to take what we've initially mocked up and make it even more impressive. And then it'll be ready for use in collaboration with SAMHSA for a nationwide rollout in the early part of 2022. So this is a little bit about what's to come down the pipeline, specifically when it comes to our SBIRT for eating disorders rollout. But in the meantime, I would encourage you to check out some of the resources that we have available on our site. And also, more importantly, to get signed up for our newsletter if you're not already signed up for it. That's going to be the best way to make sure that you have the most up-to-date information about when we're rolling out SBIRT for eating disorders. We're going to do a big press push and all those things too. But in terms of just getting access to the tool on the ground, signing up for our newsletter is the best way to do that. So in addition to that, on our website, you can find this toolkit that we've created for primary care partners, for anyone who's interested in working or collaborating with us. There's all kinds of information in terms of infographics, there's videos, there's our newsletter archive. So please make sure to avail yourself of those resources. In addition, for those of you that are in primary care, we've also come up with just a brief checklist in anticipation of the rollout for SBIRT. So what are some of the signs and symptoms of eating disorders to be aware of? These are just some quick screenshots for you to take a look at. What are some of the early recognition signs that steps that you can be taking? What are some of the questionnaires that are validated out there for screening in case the SCOF isn't one that necessarily works for your practice? Again, you can find all of this on our website. You can also go to our full list of resources in our resource library, where on the left-hand side, you can see that we have a number of different filtering capabilities. So all of the resources that we have there can be filtered down depending on whether or not you're a therapist, maybe you're a primary care doc, and you want to learn specifically about medical management. It will tailor those resources based on some of those filtering capabilities. And then also our training center that I know Lachelle mentioned at the beginning of our webinar. All of the trainings that we have done so far in this webinar series are logged there. We have a wealth of offerings for primary care docs. We have a number of different offerings for folks that might be behavioral health facing and are interested in learning about, let's say, conceptualizing recovery or working with certain minority populations with eating disorders. All of those are available free on our website. They're also associated with free CEU, free CME. So please take advantage of any of those that might be interesting to you or to folks that are in your clinic or your practice. And just in terms of some overall summary, I wanted to leave you with some of these points, and I'm glad that we'll have some time for question and answer. And I know that Lachelle will be helping us to facilitate that. But I just wanted to kind of leave you with the overall setting the stage information of the number of folks that will struggle with an eating disorder, and knowing that folks that are in primary care or in a generalist role have a really crucial role when it comes to screening these conditions, detecting them, getting them into treatment as early as possible. And we're hoping that what we've developed with SBIRT for eating disorders will be a tool that is practical and useful for those of you who are engaged in this work. So with that, I'm going to turn things over to Lachelle, who's going to help us facilitate a question and answer session. The only other slide that I have is my email address in case anyone wants to be directly in touch after the talk. I'm happy to walk through any of this information with anybody. So Lachelle, I will turn things over to you.
Thank you so much, Dr. Pete, for such a great presentation. As a reminder, we will be sending the slides after the presentation has ended. We will now begin our question and answer segment. We have quite a few questions. For any unanswered questions, we will send those responses to you via email within 1 week from today. So just as a reminder, you will receive those responses 1 week from today via email. I'll go ahead and start with our first question, and it says, it seems that the 2 questions do not screen for restrictive behaviors. I'm not sure which 2 questions. I'm not sure if you could decipher, Christine.
Sure. Yeah. So I think the person who's asking the question is probably referring to those first 2 questions on the SCOF that are presented there. And you're right. They don't adequately screen for those sorts of things. And I think the balance here that we're really trying to achieve, like with all screenings, is the balance between specificity and sensitivity. So in this situation, we want to make sure that we are going to pick up as many people with an eating disorder as possible. So we want the measure to be as sensitive as possible, even if we have to sacrifice some of that specificity. And again, based on the research that was done, not by our group, but by lots of other folks, looking at which of the 5 questions on the SCOF were the best at detecting the widest swath of individuals with an eating disorder, those are the 2 questions that came up. But absolutely, you're right. It is not necessarily something that's going to adequately capture everyone, but we're simply trying to move the needle from no screening at all in a primary care setting to at least some screening and detecting as many people as we can. Certainly there's room for refinement. And if you have other thoughts or suggestions, I would absolutely encourage you to reach out. We're happy to take any thoughts that you might have.
Thank you so much for that response, Christine. The next question reads, can this tool be placed inside a flow sheet, for example, in EHR, such as EPIC?
Yeah, I love that question, and it is absolutely something that we are working towards. So I'll just be transparent that in terms of practicality, we had to start with a website. If we wanted to start with an EHR, we wouldn't be rolling this out for the next 5 years, probably. It's just for those of you that do this kind of work, you're aware of how challenging it can be to get things into the EHR. But from our perspective, when we built this and we started to develop this as a concept and as a protocol, the whole goal really is to cannibalize it, to put it into an EHR, because ultimately that was the #1 thing that we heard from the primary care docs was, yes, a website is fine. We're not going to use an app, a standalone app. So a website would be better, but even best is going to be to have it already embedded in the EHR. I think there are a number of positive signals that we've had from some folks who are in the know in some of these larger EHR systems like Epic or Cerner. We've had some really positive discussions early on about this becoming a reality. But for now, in terms of the rollout, we're going to start with this. And then eventually, yes, we hope to have it placed into a workflow very similar to what you might do for best practices around depression, anxiety, any of those other kinds of conditions. Great question.
Thank you again, Christine. The next question reads, is the screener and referral PDF available in Spanish?
Wonderful question. It is not as of yet. However, when we do our launch, we will make sure to have that available in Spanish. Thankfully, on the team, on the NCEED team, we have someone who is an expert in Spanish language translation for specifically around eating disorders. So we will make sure that that is available in Spanish. Great question.
The next question reads, any cultural adaptations needed for Latino/African American, Vietnamese, LGBTQ populations?
Yes, thank you so much for that question. And one of the slides that I didn't have in this presentation are sort of our planned iterations for SBIRT for eating disorders. So knowing that this is where we're starting from, we also knew that not only do we want this to go into the EHR, we knew that we were going to have to make adaptations depending on the different types of patients that might be in the clinic. So to that end, SAMHSA actually has developed or stood up a couple of different centers of excellence that we are thrilled to be working with in the coming months, actually. So for those of you who may not be familiar, SAMHSA actually funded several centers of excellence, specifically focusing on behavioral health disparities. So in the last, I think it was 6 months, they funded a center of excellence on behavioral health disparities in the African American community, in the LGBTQ community, for families, I think the homeless community, and then one other. But we plan on working with all of the different SAMHSA COEs to make some of those adaptations to make sure that the content that we have is appropriate for the patients that it's serving. Certainly that's not an exhaustive list of the iterations that we'll be undertaking, but it gives you a sense of where we're headed.
Thank you once again for that reply, Dr. Pete. The next question reads, is Recovery Record a standalone ED treatment app? I thought this app tracks ED symptoms and is intended to be used in tandem with a treatment team.
Yeah, that's a great question. So one of the things that I don't think is clear from that particular screenshot is that there is a self-help version of Recovery Record that is designed to be sort of used as a monotherapy. So that's one possibility. But if there are other suggestions about other treatments or other things that are sort of self-help type interventions, I would love to have a list of those. We'd be open to any of those kinds of collaborations. Again, nothing that was shown on that screen was meant to be an exhaustive list. These were just mock-ups with some initial ideas. So certainly feel free to make sure that you're giving us feedback on that as well.
Thank you again, Dr. Pete. The next question reads, in what populations has this tool been checked for reliability?
So if you're referring to the SCOF, that's a great question. So the SCOF itself has largely been validated in adult populations. And that's one of the real challenges that we have when it comes to children and adolescents. We can talk about that separately, but the SCOF has been validated for adults in terms of being a valid and reliable screener. Again, screener, not diagnostic tool, but a screener for eating disorders in a primary care setting. So it's actually been used in, let's say, campus health settings or in other more generalist type settings. So we know that there's reliable and valid information when it comes to using the SCOF in this way. When it comes to evaluating SBIRT for eating disorders, this is a novel protocol. This is the first of its kind. This is something that we have developed here within NCEED. And so we are looking forward to doing some formal program evaluation, some formal data collection with some different primary care partners that we have some discussions going on with, and we'll be able to share those data as we do the rollout.
Thank you once again, Dr. Pete. I'll read the next question. Do you have resources regarding finding treatment for individuals with eating disorders?
Yes, we certainly do. And that will be included in the referral guide that we give to patients. But in the meantime, if you yourself are a provider and you're looking for those sorts of referral sites or information, you are welcome to be in touch with us here through our auspices. You can shoot me an email, but there's also some information about that on our website. So you're welcome to take a look at the offerings that are there.
Thank you once again, Dr. Pete. The next question reads, IADEP has a task force working on this identical issue. How are you addressing linking PCPs to ED specialists, therapists, dietitians, family support, etc.?
Yeah, so it's interesting. I'm aware of some of the efforts that IADEP has going on in this arena. And I think that really what we are trying to focus on with SBIRT for eating disorders is the earliest part of that pipeline. So really just getting, and we talked about this in our UX sessions, what we're really trying to do is to just get PCPs to consider that an eating disorder diagnosis might be part of the clinical picture. Just even getting them to think, maybe I should include an eating disorder screening in sort of the routine screeners that I give to people. That in and of itself represents a huge clinical shift. So just even introducing that as a concept is going to be an enormous win when it comes to detecting people with eating disorders. The next part of that pipeline is exactly what IADEP is talking about. It's that integration of connecting people who are in that primary care setting with eating disorder treatment providers for patients who are receiving ongoing care or ongoing management. I am happy to have some of those conversations. For those of you who may be on that task force, please reach out to me. I'd love to talk to you about that. But in terms of what our protocol is designed to do, it's really designed to kind of be at the earliest part of that pipeline to just sort of socialize this idea that eating disorder screening is something that's important to be happening in a primary care setting, and saying, and hey, look, we've already developed this protocol in conjunction with PCPs that should work in your particular setting. And then as other parts of the pipeline kind of get involved, then we're all kind of working in tandem. We've got everybody kind of moving in the same direction.
Thank you once again, Dr. Pete. The next question reads, referral to treatment can be so challenging with patients without insurance. Any suggestions for working with low-income patients without health insurance when it comes to referring to treatment?
Yeah, gosh, boy, we could talk all day about this and just how challenging it is. As a clinician here in North Carolina, the number of folks that we end up seeing who are covered by Medicare, Medicaid, or are uninsured, or frankly, just underinsured, it is such a challenging problem. And in the absence of having a magic wand where I can say, here's a list of 50 places that you can send someone, what I would say is to check with any of the existing networks that you have in terms of eating disorder providers, because many of them will offer either sliding scale appointments, or some of them do pro bono work. Also, Project HEAL has treatment scholarships that can enable folks to access that treatment for folks that might not otherwise have means. Depending on the level of care that folks are looking for, a lot of the places that offer inpatient care that are university-based often will take Medicare or Medicaid. So I think it's important to kind of be thinking about the specific resources in your area. The other thing I would say is that there are some really great free online support groups. Even though it may not take the place of a full suite of treatment, we know that it may not meet all of those needs. Organizations like the Alliance for Eating Disorders offer free support groups for folks, and they're doing them all virtually in light of the pandemic. So again, is this a perfect fit? No, but there are at least some resources that are out there. So if there are specifics, however, I would encourage you to be in touch with us, and we can see what we can do to kind of answer any specific questions that you might have for patients that are in your area.
Thank you once again, Dr. Pete. The next question reads, has this been implemented in college health centers?
So if the person asking the question is referring to the SCOF, the answer is yes. But if you are referring to SBIRT for eating disorders as a whole, the answer is pretty straightforward. It's a no, since it's not yet developed. We're hoping to launch in the spring. And again, I really want to stress this idea that we are leveraging an existing framework for screening, brief intervention, and referral to treatment, but it being applied to eating disorders is a completely novel strategy and something that's been developed here at NCEED.
Thank you once again, Dr. Pete. The next question reads, I am involved with running a summer program for teens during which we as administrators often see ED behaviors in our participants. We are not PCPs, but want to ensure that the 15 to 20-year-olds with whom we work get care and resources. What would you say to someone in our positions first? And then second, what is the most practical way to support these young people, especially since we are not PCPs?
I love that question. Thank you so much for asking that. So I think in answer to the first part of your question, I would say shoot me an email, because I'd love to have a discussion with you about how NCEED can help support some of the work that you're doing. The other thing I would say is that in terms of the sort of future plan 5-10 years down the road for NCEED and SBIRT for eating disorders, is we're also thinking about not just frontline clinicians, but frontline individuals, and how we can adapt the content of SBIRT for eating disorders to be relevant, not only for medical professionals, mental health professionals, but anyone who's on the front lines of detecting an eating disorder. And when we're thinking about this, we certainly think there's going to be relevance for school settings. We think there will be relevance for community settings. Anybody who's in, like you said, in these summer programs that you might be leading, people who are leaders of their faith-based communities, these are people who honestly are probably going to hear about eating pathology or an eating disorder, maybe even before a primary care doc or a pediatrician. So we do have future plans to make some of those adaptations as well, to make sure that this protocol is something that can be useful for any kind of frontline person. But in the interim, for the person who asked this question, there are resources on our website in terms of messaging around eating disorders, what you say to young people with eating disorders, how to avoid triggering languaging, all those sorts of things. So I would encourage you to take a look at the resources that are there. And if after reviewing those, it doesn't feel like it quite fits the needs of what you all are doing, please reach out to us for that kind of technical assistance. That's really what we're here for, is to provide that kind of ongoing education and training to anyone who's engaged in this kind of work. So thank you for that.
Thank you once again, Dr. Pete. We'll try to get 2 more questions addressed before we end our session. The next question reads, what percentage of the 15-minute appointment ends up being dedicated to this screening and intervention?
Yeah. Good question. I think it really kind of depends on the resources that are available in the clinic. So we envision that for people who or clinics that have an electronic medical record, they might be able to send the screener to the patient in advance of the visit. So for many of you, I'm sure this is very common in your primary care visits, where your doctor's office is probably sending you 3 or 4 questionnaires that you have to fill out before you come in. There's no penalty, of course, if you don't fill them out, but it helps to facilitate the visit, right? So in that situation, really the major component would be having the discussion with those scripted prompts and referring a patient to care during the visit. So it may only take a matter of a few minutes. If, however, you're needing to do the full thing during the visit, we also envision that people like CMAs and CNAs could be really crucial in this. So as they're rooming a patient, as they're getting a patient ready to see the doc, they can ask some of those questions, maybe verbally, maybe paper and pencil, whatever makes sense for the clinic visit. So I think it really kind of depends on how well resourced clinic is. But again, that's why we made SBIRT for eating disorders into something that's really flexible and really adaptable depending on the type of setting that you're in.
Thank you once again, Dr. Pete. The next question reads, will a video of this presentation be available for use with our clinics?
So this video will certainly be available. This will be on-demand content in our training library. However, we are also going to launch a specific training when we do the nationwide launch for SBIRT for eating disorders. So we will have kind of a standalone, for lack of a better term, implementation webinar for folks that are hoping to use this in their clinics. So the answer is that yes, this presentation will be there, but there'll be an additional one that's kind of more specific to the actual build and the full implementation in your clinic.
And the last question we'll address today, the others will be sent via email, is what is the plan for piloting this tool?
Yes, there are multiple plans for piloting this tool. I think, we have a number of academic partners who are interested in working with us in terms of overall piloting. There are also some other plans, some other discussions with groups that might be interested in doing this in a smaller scale. But overall, if whoever's asking this question has any interest in being a part of those collaborative efforts, I'm happy to have that discussion. I think the more data we can collect, the better, and the better we can get at refining this and making sure that it's really adequately meeting the needs of not only the providers who are using it, but also the patients that it's serving. So absolutely, there are plans for that, and when they're more formally in the works, we'll be able to share some of those data.
Thank you once again, Dr. Pete. If you have any closing statements or any information you'd like to share before we end the webinar today?
Nope, I think that's it. I'll just make sure that everything is available so that you can send it out to the larger group.
All right, thank you all for attending today's webinar. As a reminder, we will be sending these slides and the questions to you once the webinar has ended, and you will receive responses to the unanswered questions within 1 week from today. This session will be available on demand at our training center, which is www.ncedas.org/training. Thank you all once again for your time and for attending today's session.
Thanks, everybody.